Hi, and welcome to the Grace Supportive Care webinar series. Joining me today is Dr. Charles Loprinzi. Dr. Loprinzi is a professor of oncology at the Mayo Clinic in Rochester, Minnesota, widely regarded as one of the experts in supportive care in the country and across the world. We're going to be chatting today about chemotherapy-induced peripheral neuropathy, or CIPN. Dr. Loprinzi has actually written the ASCO 2014 guidelines on CIPN and is also the author of the up-to-date section on this topic. And on a more personal note, he actually interviewed me for oncology fellowship 2 years ago at the Mayo Clinic, and I've looked up to him ever since. He's been an e-mentor or a virtual mentor of mine, helping me write and design one of my current clinical trials. So it's an honor to have you today, Dr. Loprinzi.
It's a pleasure to be here with you.
So let's start chatting a little bit about CIPN. Could you just tell our listeners what it is and what we mean by chemotherapy-induced peripheral neuropathy?
So chemotherapy-induced peripheral neuropathy, a big problem for a lot of patients. A number of chemotherapy drugs cause this problem. Not all chemotherapy drugs cause the problem, but a number of them do. Drugs that are well known for causing this problem are the taxane drugs, paclitaxel, docetaxel, nab-paclitaxel, or variations of the taxane drugs. And then the platinum drugs, cisplatin, oxaliplatin. Carboplatin is another platinum. It doesn't cause as much neuropathy. But those are the drugs that cause a lot of this. There are some myeloma drugs also, like bortezomib, that cause this particular problem. There are a few other drugs that cause less of this problem, like eribulin and that sort of thing, but those other drugs I mentioned are the primary ones. It's something that comes on with chemotherapy after starting chemotherapy, and it consists of numbness, tingling, and pain. Some people say shooting or burning pain, although it's not always described as shooting or burning. And those are the three things that are associated with it. It can be a major problem that can limit the amount of chemotherapy that's given. Some people get it more than other people get it, and we're trying to figure out better who is at more risk for getting.
Understood. So, and among the chemotherapy agents that you mentioned, seems like these chemotherapies are often used to treat a wide variety of tumors. So the platinum agents that you mentioned can be used to treat head and neck cancers, bladder cancers, GI malignancies, your taxanes in breast and prostate and lung. Vinca alkaloids is another one of our chemotherapy classes, which is often used to treat leukemias, lymphomas, and of course the myeloma treatments like the bortezomib, the IMiDs, the thalidomide, the lenalidomides. So basically a lot of patients are at risk of developing chemotherapy-induced peripheral neuropathy, like you said. You also mentioned that not all patients are at equal risk, if you will, and we perhaps don't know exactly who will develop peripheral neuropathy. And that's one of the things that we struggle with, is identifying those patients and potentially doing something for patients who may be at higher risk. So for a patient or an oncologist who's going to potentially start a patient on one of these drugs, what can they do before starting the chemotherapy or during the early phases of chemotherapy to potentially prevent this from happening or reduce the severity?
So the other thing that comes up with what you just said there is who is going to be at risk. People who have diabetic neuropathy or other neuropathies, they're going to be at risk. If you have a person that has diabetes and does not have neuropathy, which can be a chronic problem with diabetes over a long period of time, with some drugs, especially the taxanes, it's been shown that those people are at more risk. And there are certain families, Charcot-Marie-Tooth, a relatively rare neuropathy that people get without necessarily something causing it. But if they get chemotherapy and they're in one of those families, they may be at higher risk for getting it. In terms of trying to prevent the problem, the last time we wrote our ASCO guidelines, we said there were about 40 studies that had looked at this, and none of them had been proven to be able to prevent the problem. That was a few years ago and all. There's some information, again, nothing that's proven beyond a shadow of a doubt, but there's some information that those who exercise, either beforehand or after starting, can reduce the neuropathy problem. again, not proof, but a good idea to do anyway, is exercise. There's some information that is something called cryotherapy. If you cool the hands and feet, particularly with paclitaxel drugs, that might help decrease the amount of neuropathy. Similar to if you cool the head, may decrease the amount of hair loss. Similar sort of process, it's thought, but not absolute proof that that's beneficial. But it's not, that will decrease blood flow to that area and therefore decrease the amount of chemotherapy that gets to the nerves that cause the problem. Some people, at a variation of that, have put on tight gloves, surgical gloves, one size too small, put two on the hand that could decrease blood flow in that area. And again, not proof, but suggestion. It's actually peculiar that oxaliplatin has a particular sort of neuropathy, which is a cold sensitivity neuropathy. And there's actually been some information that actually in patients getting oxaliplatin that cooling the hands might actually decrease the problem, the development of the neuropathy, the hands and feet. There's no free lunch, if you will. There are the gloves that have been utilized from that occasionally have caused frostbite. So that has to be kept in mind for that process. And people are developing things where they do some cooling and some compression and all that stuff. So that's an area of the research similar to the hair cold caps. That was done back when I was a fellow, which was decades ago. Started in the 1970s or 1980s is when they started doing that. And it wasn't until the last 5 years or so where they finally got something that actually works reasonably well. Not perfectly, but reasonably.
And I think there's some recent data about reducing the risk of mucositis or stomatitis with oral cryotherapy as well when we swish ice chips in the mouth. And so potentially that's something that supportive care trialists can look to address in the next few years, hopefully.
So yeah, that is true. And actually it was our research team who actually was the first one to show that the ice chips in the mouse decreased 5-FU induced oral mucositis. It was actually the nurses who came up with the idea, because 5-FU has a short half-life, which means when you give an injection to the blood, about 10 minutes later, only half amount of drug was there, and 10 minutes after that, half amount of drug was there. Other drugs, it can be there for hours. But they said, what if we put ice chips in the mouth 5 minutes before we give the bolus of the 5-FU, replenish them for a total of 30 minutes, with that decreased mouth sores. And clinical trials demonstrated that it decreased mouth sores by about 50% for the amount of mouth sores over the next week or so. So yes, there's actually one of my fellows, he was a resident at the time, became a fellow in oncology, wrote a paper, cryotherapy from head to toe of the different things for hair loss. You can actually prevent nail toxicity. Some of the drugs, such as docetaxel, causes a lot of nail toxicities where the nails can actually fall off. There are data that actually that can help decrease that problem also.
Maybe that's why you live in Minnesota, Dr. Loprinzi.
We just have people stick their head out the window. So we actually did demonstrate that some chemotherapy, like 5-FU, actually can cause some conjunctivitis, some irritation of the eyes. And we, years ago, with women who actually had that problem, because it was mostly breast cancer patients, I don't think the study actually was all women, but had that problem with one dose of chemotherapy. We gave them then, randomized them to get ice packs over their eyes versus not, and it did have a tendency to decrease the amount of eye toxicity in that situation.
Wow, so to summarize, there's no proven single oral or IV drug that can potentially prevent it, but what I'm hearing is oncologists should try to address neuropathy from other causes, whether that be through diabetes, through inherited neurological disorders, folate deficiency, thyroid testing, make sure that there is no easily reversible cause of neuropathy. We can ask patients who are drinking a lot of alcohol to cut down to potentially reduce the risk of them developing neuropathy from another cause. And then we just start this chemotherapy. I think next we want to know, how does this develop? Is this usually insidious and comes on slowly, dose dependent over time, or does it usually out of the blue after the first cycle of chemotherapy? What's the usual timeline and what will patients experience?
So good question. I'm going to break it down a little bit because there are two forms of neuropathy. There's what we call an acute neuropathy, which happens while you're actually getting the treatment and or within the first two or 3 days of getting the treatment. And then usually gets better over the next several days. So a week later, it's much less than it was, but it then comes with each dose of chemotherapy. That can be a problem, and we call that acute neuropathy. And let me talk about that for a while here and then go on to the more chronic neuropathy, which is the bigger problem. So the acute neuropathy is well known with oxaliplatin. And when you give that drug, while you're giving it or within hours, patients can get trouble with cold sensitivity. Their hands are very sensitive to cold. If they drink cold liquids, it's very problematic there. It can also cause some trouble with swallowing and some cramping. And it can be a big problem. It comes with the first cycle. It tends to get better over the next few days, but then comes again with the next cycle. The second cycle is a bit more of a problem. And then the third and fourth and fifth cycles, all of that stuff. Eventually, those symptoms go away. We actually looked at this prospectively in patients while they're getting chemotherapy. We didn't have the wisdom to say, let's follow these cold sensitivity things for a month or two after finishing chemotherapy to see how long it takes till it goes away in most patients. We're going to do that in future studies, but nobody's really done that now. So another drug, paclitaxel, for years and years, it caused a problem that when you give it a day later or so, and this doesn't happen usually while you're getting the treatment, like the oxaliplatin one can be, a day later people would get aches and pains, and it would be quite a problem, especially when we used to give big doses once every 3 weeks. Now for breast cancer, we give smaller doses once a week. It's less of a problem. But when we gave big doses once every 3 weeks, I would give the patient some opioid medications. This is before the opioid worries that we've had so much. Because otherwise they would have such pain that they would need it, and they'd call me on a Friday night at 10 o'clock. So I got in the habit of giving them a few today so they would have it, so they didn't have to try to get it at 10 o'clock on a Friday night. And that was called arthralgia myalgia, as if it was a joint or bone or muscle problem. The current thought that I came up with years ago is that this is actually a form of acute neuropathy. It's actually a neuropathy sort of problem. It's not really pain from the joints or the muscles. It's in the area of the trunk where there are a lot of joints and muscles. So that's acute neuropathy. And those usually are more acute and get better. Now, the more chronic process is something that comes on gradually over time to varying degrees in different patients. But and some people will get it after the first cycle or two of chemotherapy. And let's say with paclitaxel, we give 12 weeks of paclitaxel when treating breast cancer, which is mostly what I've treated in the past. But it would come up. And some people would get some trouble. What is the trouble? Numbness, tingling, and pain. Numbness and tingling come on first, and you almost never get pain without numbness and tingling. And then it gets to the point where it gets more and more prominent. And then when you stop the chemotherapy, when you stop paclitaxel, it tends to get better, but some people still have a big problem with it months and years later. When you give oxaliplatin and you give a cycle of the whole course of that problem actually, after you stop chemotherapy, continues to get worse for about 2 or 3 months. And then it starts to get better on average. But there are some people who have a major, major problem with it for years and years after stopping it. So those are the different things. The reason the oxaliplatin, we call that coasting phenomenon, somebody labeled it that way. And they used to think that it got worse after you stopped the chemotherapy. But when we look at the time up until we give the last dose of chemotherapy and the 3 months afterwards, the slope of the problem is the same during the last few months and during that other time. And so in my mind, it's just that the last dose takes about 3 months before it does all of the damage it's going to do, but then gets better over time.
All right. So again, what we're hearing is there's an acute form coming in within hours to days, often going away, more often with oxaliplatin, tips of the fingers, perhaps some mouth numbness and tingling, but potentially then getting better. And this more sort of severe, dangerous form known as chronic neuropathy, which is coming on over months, is dose dependent and cumulative. So the more chemotherapy you give, the more damage that's happening to the nerves. These symptoms are often happening at or are starting at the tips of our fingertips and then proceeding towards the centers of our body or proceeding proximally. And as you mentioned, Dr. Loprinzi, that these often start with sensory symptoms, so numbness, tingling, and pain, but if not treated, can evolve into motor or movement dysfunction as well. Is that right?
So the main part of the problem is the sensation part of the problem. That's the main part. There are some people who, in fact, can get weakness, muscle weakness, and that sort of thing. And I think that the sensory part of things is 90 to 95% of the problem, and this motor problem is 5 to 10% of the problem. Yes. Okay.
So if I'm a patient or a caregiver who's never experienced chemotherapy-induced peripheral neuropathy yet, and I have a question for you is, why are these two people stressing too much about some numbness, tingling? Do you have some patient stories about how this symptom can affect someone's life on a day-to-day basis?
So when I'm treating patients, and again, weekly paclitaxel, 12 weekly cycles, and I'd see the patients every month or so with it, every 3 to 6 weeks. And I would always ask the question, are you having numbness, tingling, pain? And if they say no, then you're pretty darn good with things, and you continue on with it. If they're starting to get a little bit of the problem, I'd say, well, let's continue with what we're doing, but I want to hear if it gets much worse. If it starts to get worse and you continue with the drug, then it can be really, really bad and last a long, long time. So a lot of the patients we're treating, we have breast cancer that's been curatively treated. They've had the tumor removed. There's a risk for recurrence, and we're trying to decrease that risk of recurrence, and we're decreasing the risk of recurrence by 5 to 10 percentage points, let's say, so that a patient chance of doing well was 80% if they didn't have the chemotherapy, and we move it up to 85% if we give them the chemotherapy. But if they've had fairly significant neuropathy after 6 or 8 doses, I say, I think the chance of us improving things with giving the last 4 doses or 6 doses, whatever it gets to 12, is maybe 1 to 2 percentage points increased benefit. But this neuropathy is the other thing. It'd be a problem for a long time, and we try to make an informed decision about whether or not we stop the chemotherapy a bit short of what we had initially planned. It's a judgment call from that situation in there, and we talk about it and all. But I oftentimes will stop the chemotherapy. Some doctors decrease the dose, and that's not bad, sort of thing. But I usually get to the point of saying, is it bad enough to stop? And if it is, then I stop the drug. And if you want to say, well, let's give another full dose or two, and that, or decreasing the dose a bit is another intermediate way. My tendency is usually I give it or I stop it.
All right. So the reason we're worried about patients developing this is that we're worried that this may interfere with their everyday activities. So buttoning or unbuttoning their shirt or picking up some loose change from the floor. Our program director here at Johns Hopkins, Dr. Ross Donehauer, is a GI cancer expert, and in the first day of clinic with him always tells us that we're really focusing or need to focus on the quality of life of patients. So if a patient with metastatic colon cancer comes to you, your job is to make sure that whatever time they have, they're having a good quality of life, and uses these terms. You don't want to bazooka their fingers so they can't have a hot cup of tea by themselves. So that's what we're really worried about from the patient standpoint. And as you said, from the oncologist standpoint, we're factoring in this toxicity into whether the chemotherapy we're giving is really going to help you if it's going to cause you such severe symptoms.
Yes, you're absolutely right. And then some with the colon cancer process, new data over the last few years have come out to support that instead of giving 12 go-rounds of this chemotherapy in the patients who had curatively treated colon cancer, everything removed but risk of recurrence, but that six go-rounds is about as good as 12 goes around and a lot less neuropathy. In the metastatic setting, the same sort of thing. And oftentimes what you can do is you don't have to stop all of the chemotherapy the patient's giving, because oftentimes we give 5-FU, 5-fluorouracil, plus the oxaliplatin, and you can continue the 5-FU part of things and stop the oxaliplatin, which is the one that causes the neuropathy. The 5-FU does not cause the neuropathy.
Understood. So suppose now, Dr. Loprinzi, we have a patient coming to us in clinic who's having quite severe neuropathy in the sense that they have numbness and tingling that's extending from, say, their fingertip to the whole of their palm. It feels numb. They sometimes have pain, especially at night. They're very unhappy. They're not able to hold up a cup of coffee themselves. They speak to their oncologist, and we decide to pause chemotherapy and, quote unquote, hope for the best and that it slowly maybe gets better. Are there any drug treatments for a patient like this?
So yes, and before I get to that, let me mention one other thing, which I didn't mention, that a big problem for patients with this can be, because the problem is not only the hands. We've been using our hands because it's easier to do that than to show our feet, that if we have shoes on, but it's as big a problem in the lower extremities than in the upper extremities, especially longer term after you're finished there. And some of these people have trouble with walking and falling and that sort of thing. So it's not necessarily just a minor thing of a little ache or pain that people can fall and hurt themselves. So what can be done for treatment of established chemotherapy-induced peripheral neuropathy, or CIPN, as opposed to prevention, what we were talking about before there. So from a treatment standpoint, one, exercise. There is some information that exercise might be good for that sort of thing. So that's always good to do for all of us, including myself. Don't exercise as much as I ought to do. I know you exercise yourself all the time, very appropriately, I'm sure. But in terms of drug treatment for that, there is, when we wrote the ASCO guidelines several years ago, there was one drug that actually demonstrated what we call statistically significant benefit. That patients who had chemotherapy neuropathy asked to participate in their neuropathy by having them fill out questionnaires in terms of how bad their neuropathy was, and followed them over time, and they got duloxetine, which is an antidepressant type medication, versus a placebo medication. Okay, so they looked the same, so they didn't know which one they were getting. And the pain score in patients, and they had to have pain for neuropathy of at least 4 out of 10, I think was the limit. It might have been 3 out of 10, but they had to have significant pain. And the average amount of pain for these patients was 6 out of 10 for both groups of the patients, the placebo and the duloxetine patients who could receive each of those. And with the placebo treatment over the time period, which I believe was 6 weeks, was the pain decreased from 6 out of 10 to 5 out of 10. So it decreased a little with placebo. It's what people have heard about the placebo effect, and always seems to be that people get a bit better with given anything. The patients who got the duloxetine, it decreased to 4 out of 10, which was statistically significant. The chance that would happen by chance alone would be 1 in 500 or something like that. So we consider that a significant benefit. It's not a great benefit. It's a lot to be needed for that. But that's the one drug that we have that's first worth using in that particular setting. There are some patients who have more than a 1-point decrease. They have several point decrease, and some people who don't get the decrease. So that's the one drug, the duloxetine. You start at a smaller, at half the regular dose, and then you go up to the full dose after a week of that. So that's the one drug that's first recommended in this situation.
So duloxetine potentially helpful, and this is mostly just for the pain symptoms, or do you think this could also help with the numbness or tingling?
So it was mostly set up to help for the pain, but it did seem to help to some degree for the numbness and tingling.
All right. So until now, we've spoken that it's really important to be careful with things you do in the house as well. So making sure not to fall. Several patients who have neuropathy in their feet complain that they almost feel like they're walking on jelly. And so falls can be a major, major cause of both morbidity and even death. And so taking care not to fall, doing rehab procedures is very, very important. And then using duloxetine, a drug, to potentially reduce the pain associated with neuropathy. And then I know that you published a paper just a couple of months ago on using scrambler therapy to potentially treat the symptoms of chemotherapy neuropathy. Can you talk to us a little bit about that?
I can. Scrambler therapy is a treatment where it's somewhat similar to TENS, T-E-N-S, trans-electrical nerve stimulation, which a lot of people have heard about. You can buy little machines for 10 to 20 bucks. You put them on and it gives some electrical stimulation. And it's thought that when you have sensory input to a place, and it goes to the spinal cord, it doesn't let in the pain symptoms for that thing, and it blocks the pain symptoms. There had not been a lot of data suggesting that TENS was helpful in this situation when we started this study I'm about to tell you about, but new data suggests that it might help things a little bit. So the scrambler therapy also puts on electrodes on a patient. It gives some stimulation to those areas. It's not done at home with a little machine. It's rather a bigger machine that looks like an electrocardiogram or ECG machine that you put on up to 5 sets of electrodes, and you stimulate the areas and you around the areas of pain. And the mechanism it's thought to be is that you train the body that this really isn't pain that they have here. This is a different sensation, and you get the body to be retrained. And so in this particular trial, we randomized patients to get TENS machine for 2 weeks versus the scrambler therapy for 2 weeks. And the patients who got scrambler therapy had more of a decrease in their symptoms than the patients who got the TENS treatment. So it was a pilot trial. It was not set up to be the final definitive trial, and that's where that is. This is not available at every place in the country, and it takes some expertise to use it, but it seems to be helpful in this situation. It's not only for neuropathy pain, but other sorts of chronic pain syndromes for scrambler therapy.
And how often do we give this treatment, and for what duration of time?
So the idea is usually it's given up to 2 weeks daily, Monday through Friday in the office for that time, as long as the patient is getting benefit and continue to get benefit. If the pain symptoms completely go away, then you could stop earlier than that. Now, the benefit from these patients can last after you finish it for weeks to sometimes months or years. But there's more and more data supporting that patients actually may have to get booster treatments from time to time and get that process to help keep it under control.
Perfect. And anything on the horizon that you see, Dr. Loprinzi, for patients, researchers, clinicians, things to look forward to, things that they should be thinking about to prevent and potentially treat this horrible symptom?
So there's a lot of research that's going on. Several different drug trials are ongoing to try to see, can we find something that's better that will help treat this neuropathy or prevent this neuropathy. But nothing more that we have in clinical practice in 2019, August, right? That's what we're in. August 2019, that's worth recommending for standard approach.
Perfect. So hopefully when we record this next year, we'll have a few more ways to help our patients.
I agree.
Thank you so much for joining us, Dr. Loprinzi. Until next time.